Welcome to the Osteopathic Lyceum podcast. What we're going to do today is do our best to be brief in going over the interface between hands-on practitioners and radiology. Now, there's two basic types of radiology, or not necessarily basic, but two branches of radiology. You have interventional radiology, where the diagnostic images are used as part of a medical intervention. So things like placing stents to open arteries. We're not really going to be speaking to that side of radiology. The other branch of radiology is diagnostic radiology, and that's something that most hands-on practitioners are going to interface with in some way. Now, depending on the particular location that you reside in the world and the legal bounds around your hands-on practice, to be you a chiropractor, a physio, an occupational therapist, an athletic therapist, or a massage therapist, a osteopathic practitioner, so on and so forth. There are varying regulations in varying locations around the ability to order radiology or diagnostic images or diagnostic radiology. For the most part, in most places, most hands-on practices can't really order the images, but they can refer to a physician with some insight as to where a possible injury may be, so that the physician may have improved guidance as to where they might want to order the image or images. So making that point is simply to suggest that if you're talking in the educational setting about what should be taught to hands-on practitioners with respect to radiology, interpretation of images is likely not something that is required in most jurisdictions for most hands-on professions in most of the world. Some places that will be a requirement. So if you're looking at, say, something like the World Health Organization documents for training in complementary alternative healthcare practices, such as osteopathy, if you note that there's a requirement for radiology and something like that, then you can really simply look at your own jurisdiction and say, hey, I'm not even allowed to order these. I'm definitely not allowed to interpret them. Therefore, as an educational intervention, I probably shouldn't be teaching people how to interpret an image. What I might want to teach them, as we're going to attempt to briefly discuss here, is the basics of the different types of diagnostic images that you'll likely come across, and then some concepts surrounding how they work and really what they're good for identifying. Now, as a very, very broad statement, what I'll say is that as a hands-on practitioner, radiological images or diagnostic images are not necessarily going to tell you what to do in most cases. They're going to tell you what not to do, because really what they're going to identify is where there is a break or a tear in some structure. So a break in a hard tissue, such as a bone, a tear in a soft tissue, ligaments, muscles, not likely an organ, but any form of soft tissue. If there's some form of disruption, the appropriate image can identify that, and it will tell you not to work in that region, not to move, because if something's broken or something's torn and you introduce external forces and external motion into it, you're more likely to cause problems with that break or with that tear. So we're going to be as careful with that as we can. So radiology, broadly speaking, or diagnostic images for the hands-on practitioner in almost every profession, in almost every location in the world, is telling you what not to do. It's giving you a good contraindication. Consider the environment of observation of hands-on practitioners. We're outside of the patient. We cannot see the internal processes. We can get hints, we can get proxies as to what might be going on inside of the patient's body based on motion. So we can identify things that move too much, things that don't move as they should, things that don't move at all. And those are all hints, right? So when something's lax, we can think possibly there might be some soft tissue disruption within a joint structure. So you're thinking ligament more than anything else. When something doesn't move almost at all, sometimes you're actually thinking about a tear, which is interesting. It's like a muscular tear. Now, that's not always the case. Sometimes you get way more movement, but with muscular tears, sometimes you get a major restriction in motion. So this is variable. If you are to work on those things, or if you were to get those signals, what you would want to do is send the patient to the appropriate referring professional so that the images can be taken. So if you're concerned that there's a possible break or a possible soft tissue tear, you want to send on for imaging. unless you're in one of those jurisdictions that allows you to order that through however your healthcare system happens to be set up. Now, most places, including the place that I work, that's not a possibility. I have to send them to their physician who can then refer for images. Now, you have essentially four broad types of images. All right, so the first type of diagnostic image that we really ran across as a species is X-rays or a conventional radiograph. So those are the two terms. They're used for different reasons, but a conventional radiograph is an X-ray. Now that X-ray is essentially, you have the X-ray tube or the X-ray camera. It's not really a camera, but the proper term is escaping. But essentially, you have camera and then you have the film, and then you'll put the patient or the piece of the patient in like very close to the film. You'll turn the X-ray on, it'll take the picture, you develop it. Now, what that does is it is a density scan. So you've got a few densities that it's going to identify. The denser the thing is, the brighter it appears. The less dense the thing is, the darker it appears. So you've got essentially shades of gray between black and white, and that will help you begin to identify what's going on within the patient. The problem is you're taking a three-dimensional structure and you're collapsing it to two dimensions. So if the thing you're looking for is behind something or in front of something, depending on how you have that image set up, it might be obscure to you. So often with X-rays or conventional radiographs, you're going to need multiple angles of the same region to identify the problem. So usually you're going to have at least two angles, sometimes three, depending on the nature, and sometimes even four, just again, depending on the nature and location. So multiple angles will have to be taken. The problem with that is that you're increasing the dose of radiation, and as healthcare practitioners, radiologists are trying to minimize radiation for the patient as often as possible. The next one that you're going to run into is ultrasound. So ultrasound, you essentially have a transducer, so you have a handle. Inside of that handle, you have piezoelectric crystals that are going to be excited by an electrical current that throws a signal out. As that signal goes out, it will either pass straight through stuff, or it will pass through it a little bit and reflect a little bit, or it will completely reflect. Based on what goes through, what reflects a little bit, what reflects fully, you're going to get a signal to come back and deform the piezoelectric crystals in a slightly different way. Then you get the beginnings of your image, which can then be transmitted usually to a screen. There are times when you'll use ultrasound and the return will be audible, right? So think about things like sonar, I believe is the proper term. Essentially what you're getting is, again, electrical current through the piezoelectric crystals, signal goes out, signal comes back, and then you get an image. So you're going to get essentially a grayscale again, so from black to white with shades of gray in between, depending on what that's passing through, you'll get an image out of that. That's going to let you identify more soft tissue than it is hard tissue. The X-rays are really good for hard tissue, so bones, denser things of that nature, whereas ultrasound is going to be a little bit better for disruptions to soft tissue, or it's going to be better than X-rays for disruption to soft tissue. And there's essentially no meaningful radiation for the patient. So you're able to avoid the radiation. One of the reasons ultrasound is so useful for things like obstetrics or imaging a baby at varying points in gestation is that there's no radiation to the mother or to the growing fetus or the growing baby. So ultrasound is better at identifying soft tissues. Obviously, it will identify hard tissues, but X-ray is pretty good for that. Then you're going to run into a CT scan. The CT scan is an X-ray that spins, basically. So you have the X-ray emitter, and then you have multiple detectors, and then it's basically a tube, so it spins around. What this is good for is being able to get multiple slices through the body, and also to be able to identify things in 3 dimensions a little bit better. It's still being placed on a 2-dimensional plane, but when you put them all together, you can generate a 3-dimensional image should you need to. The challenge with a CT scan is that there is a high dose of radiation. So it gives you a really good image. It's going to be okay at identifying soft tissues. It's going to be pretty good at identifying where there is a lack of signal. So things like cysts and whatnot. It will be pretty good at identifying hard tissue and disruptions to hard tissue, so especially bony structures, but it doesn't necessarily give you the contrast at as high a resolution with your standard CT scan as say an MRI. Now, an MRI is essentially using a magnetic field specifically to line up, I believe it's hydrogen atoms, and the thing that it disrupts with a radio pulse is the hydrogen protons, I believe, and then it disrupts those. They then line up, they realign, and at the varying rates of realignment, that allows a signal to go through. And then a lot of math is done by the machine, you get an image. MRIs are very good at highlighting soft tissues. They also do a pretty good job at identifying the variation in density within a hard tissue. So the cortex, or well, not necessarily the cortex, you'll see different layers within bone in grayscale, right? So where there's a little bit more fluid, it will often be darker. And then where there's a little bit more cortex, you'll see it as closer or beginning to approach white. Now, all that being very briefly covered, as a hands-on practitioner, as I noted, what these images do is they allow for an environment of observation that you don't normally have. Again, your environment of observation is external to the patient, and as such, you can't see those internal structures, those internal processes. Now, these images are, unless you're looking at something like an fMRI or a functional MRI, are static images, right? They take a picture. Now, that picture can be done in different slices. It can be done in different ways depending on the particular method you use, the particular type of image you use. But what they're showing you is stuff that you can't directly observe. You get signals about it. You get proxies from the outside. But the problem you run into primarily is that you can't see those. So those images are the next step. So when you identify something that you think is a possible soft tissue tear or a possible break, like a possible fracture in bone, for whatever reason, you don't want to necessarily treat. You want to refer out for imaging or refer to a physician who can refer out imaging depending on your jurisdiction. And then what happens is, subsequent to the images, if the images, as long as they're the appropriate ones, come back and there is no identified break or no identified tear, you increase your confidence that treating in the region that you're concerned about happens to be safe. Now, if you do have confirmation of a break or confirmation of a tear, then don't treat there, because you're going to aggravate it. You're going to make it worse. You're going to very likely pull the tissues apart in a way that is far less than ideal and not beneficial to the patient. So for the most part, again, this is a lot of repetition, but the repetition happens to be important. As hands-on practitioners, radiology, diagnostic imaging doesn't tell you what to do. It tells you what not to do. It tells you what to avoid. Your MRIs are going to be good for essentially high resolution images in places that you can't see, very good at identifying soft tissues, and then the variation in density within a bone. It'll allow you to identify, as long as the slice is proper, things within vessels, especially when contrast is used. Your CT scans are pretty good overall images. They're very good at identifying problems with hard tissue. Soft tissue, maybe a little bit less so. Ultrasound, pretty darn good for soft tissues. X-rays, pretty darn good for hard tissues. So those are your general overviews, and hopefully that gives you a very, very rough idea. Now, the thing that I should mention and be as clear as possible, what you're probably going to run into, especially in those jurisdictions where you have no training nor legal allowance to interpret images, you're probably not going to be presented with the images. What you're probably going to be presented with is the image reports. Now, those image reports are going to provide information as to what the findings are. So it'll give you the anatomical structure, and then it'll give you a term as far as what has happened to that anatomical structure. So stenosis, spiral fracture, non-commuted, blah, 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 up, down, left, right, partial thickness tear, 1 millimeter, 5 millimeters, what have you. So the image reports require you as a professional to either already know the anatomical terms, or if it's a term that you're not sure of, to be a good professional and look that up. So you have many resources. You may have some textbooks handy, and the textbooks don't have the term, or you just want to go straight to the internet environment. You can look the term up, which then means that you have to be of an acceptable skill level to piece through all of the information you're going to be presented, because not all of it's going to be as meaningful. So your ability to consume, synthesize, and make meaning out of information you find online becomes important. So the image report is probably the thing you're going to run into, and the image report is going to tell you the thing not to do or the area not to work as the hands-on practitioner. So hopefully that gives you some insight. Very, very rough, very quick as an overview. And hopefully you were already doing all of that stuff. You were already being intelligent and cautious with respect to sending out for a referral for imaging or ordering imaging directly if you're able to, such that if you have a suspicion that there's a problem in a particular area, such as a soft tissue tear or a break, that you would refer out in some way for that image, such that when it comes back, if there is no soft tissue tear and no break, you increase your confidence with caution to treat in the region. And if there is a confirmed break or soft tissue tear, you don't treat there. So hopefully that was helpful in some way to some of you, and we'll talk again soon.